Hello, everyone. It's about 6 o'clock in the morning here Central Time, and I am so honored to be joined by Maggie Swietlik. She is the CNIO at Inova, and we're going to talk about what they've been doing out in the Virginia area for the COVID crisis. So good morning, Maggie. Thank you again for getting up so early and joining me this morning.
Well, good morning, Cheryl. Thank you for having me.
It's an absolute pleasure. I heard from Patty Senstake that y'all were doing some really cool stuff. And one of the things she talked about was what you were doing with telephone triage. Could you tell me more about that?
Yeah, so when this all happened, I think the first I caught wind of our real challenges was about, I think, March 15th. By March 17th, we'd heard that the phone lines in our primary care offices had really just blown up with calls, concerned patients and family members. And I have a background in telephone triage from Children's Hospital in Philadelphia, and we mobilized. I went to the call center where they had two nurses handling the calls for 17 offices.
Wow.
And I would say within about 6 hours, we had the nurses who were in nursing informatics redeployed to the call center on those phones and learning how to triage, how to do the phone triage aspect of it. And, in fairness, I had a great partner in the director of the call center. But our IT department, they mobilized, they got us the equipment that we needed. We were online, able to handle those calls. And within about just 3 or 4 days, we had everybody very comfortable moving along. We reached out and pulled in other nurses who really were displaced by this, where other activity had to stop and so we could pay attention to this crisis. And we pulled them in, got them trained, and we were up and running. And now, since that volume has tapered off, we've been able to pull our nurses back out and start redeploying them elsewhere.
So what was the biggest challenge to standing that up that fast?
Well, I think there are a lot of pieces. And one of the things that I can say is that, this crisis really has brought out the best in everyone. And so the biggest challenge typically is getting your IT support, hardware, software, programming, and that was not the case in this particular instance. In this instance, the biggest challenge was changing gears, retraining people. So making that pivot from the desk job, heads down, maybe, working on a system, to being forward-facing to your customers and being awake and perky and able to answer their questions. And most importantly, to be able to put them at ease. This is a real time of crisis. And we wanted to make sure that we were not only giving thoughtful, appropriate care advice, but also making sure that our customers, our clients, our patients were comfortable and reassured, and knowing that Inova was there to help them if they needed us.
Yeah, I can imagine what that would be like for some nurses. That would be very, very scary. And we all know nurses love change.
Yeah. Well, we did try to implement our software vendor's telephone triage platform during this, and we pulled back from it because we were not using it previously, and to try to implement a new workflow during the time of crisis made people just a little bit more anxious on our side. And so we reverted back to our use of phrases in our system, and that seemed to work fine. And we had great partners also in our primary care offices where they do this on a routine basis. They coached us through, we had them lead, and we really were the support in terms of not only manpower, but technology.
Yeah, that's been a reoccurring theme I've heard during these interviews, is trying to limit the number of new workflows.
Right.
Or even major modifications to an existing workflow. It's like, just make it as simple as possible. Don't give us too much to learn right now, because I've got enough on my plate.
Well, another example of that, Cheryl, is one of the things we talked about doing, this is something I had talked to Patty Senstake about, is she and I are very interested in reducing the burden of documentation.
Yes.
And we thought, okay, well, there were recommendations of how we might be able to do that. What are the things that we could stop doing during this crisis? And what we came down to, I took it back to our CNOs. We looked at recommendations, again, that came across through our vendor, and pared it down to things that we thought we could no longer require, at least for the time being. Took it to our CNOs. They had a few concerns. They said, you know, this documentation is what our nurses are used to, having it required. They're used to that. They rely on those requirements. And we'd like you to take it back. We have a nurse efficiency group. We took it back to the nurse efficiency group to get their take on it. And so where we ended up was just using, keeping everything the way it was, except one thing we removed was that requirement to do our care plans. And that is something that was covered by CMS. It was, you know, really given a waiver by CMS that during this time, they will not be looking for us to be completing care plans. And so, you know, we kind of met in the middle. While we thought we could stop doing a lot and really start charting by exception, that made people uncomfortable. And again, it was learning a new way of doing things in the midst of a time of crisis. And so while we may, you know, look at that again in the future, changing that drastically in the middle of this was going to be more stressful than it was helpful. And so no one minded giving up the care plans. So we'll pause on those for a while. And knowing that we've had, you know, documented waiver from CMS, when we go through any of our survey cycles, we'll have that to fall back on.
Yeah, I think that's going to be true of all the different kinds of surveys, accreditations. I mean, everybody's getting waivers for I know we are in the academic world. It's like, just don't worry about it, just document it as here's what we were doing during COVID. So
that's right. That's
you
right.
know, that's going to be a standard. I think that's fascinating because y'all did something differently than other places.
Mm-hmm.
And I think that really shows that we have to be really flexible and nimble and,
yes.
and agile
yes.
in today's world.
Yeah.
That what works at one place is not necessarily going to be a good answer for everybody else, which is another reason we're doing so many of these interviews,
right.
is to throw those ideas out there and people can take them and see which ones are going to work best for their facilities.
Yeah.
A lot of people have been talking to me about centralized staffing. How are they managing staffing in this really highly mobile, you know, tent cities and tent hospitals and church hospitals and school hospitals? How are you dealing with central staffing?
Right. Well, so we are a 5-hospital system, and prior to, I guess, in the past year, we've really started to adopt more systemness. We had a large change of leadership, and the 5 hospitals had been really operating as individual entities rolling up to the system office. But now we're really adopting that whole mindset and culture of systemness, which has multiple benefits. But for centralized staffing, has been interesting. We had flow pools in each of in the hospitals, and no real cross sharing of staff on a predictable plan basis. We didn't have a centralized flow pool per se. So we had, so if we were using staff from other facilities, it was really kind of a negotiated on an as needed basis, but it wasn't something that was a predictable pool of people that could be deployed. And so that's right now changing for us. We, this past week, are actually, as we speak, outfitting another call center area contiguous to our EICU, where we will house our central staffing office. And that will have central staffing for not only nursing, but our physicians and non-clinical staff. And that will be a 24/7 operation, manned by nurses and coordinators to be able to do some of the staffing. The nice piece of it is that we are looking at our models. We are now going to start that organically grow. We anticipate organically growing a system flow pool. And what we are adopting is, we've come up with some workflows. We are going to be adopting a process where our centralized staff is really reaching out to all of the facilities throughout the day, not just at 1 or 2 p.m. to plan for the evening, but throughout the day, looking at our bed board, looking at our scheduling system, looking at what's going on in our emergency departments, and seeing not only what are the numbers that our supervisors are giving us, but what's happening with the flow of patients, what's happening with the flow of staff, and having that system-wide view of everybody's site to be able to say, we can have movement, we can shift, and start having those conversations and then preparing our teams to be able to make those shifts when needed in order to cover the needs of our patients. So it's evolving as literally as we speak, but the good pieces are it's really bringing again our 5 hospitals together as a system, better communication, better insight into what's happening across the system and not just the single entities. So I'm really optimistic. I think it's going to be a great step for us, but we're just getting there.
So I'm curious, are your 5 hospitals kind of geographically in a what we would call driving distance?
Yeah, some are better than others. So the system office where the EICU is and this core is housed is really the hub of the wheel, pretty much. And our two furthest outliers are pretty good distance. So obviously, if we're doing reassignment from hospital to hospital, we are going to be very thoughtful about the geographic location as well. So that's something we will make every effort to, first keep everyone at their home base, and if we do need to shuffle staff, that we're really being thoughtful because we're honoring people for their commitment and moving them in traffic in the DC area. Traffic maybe 45 minutes away would be a hardship, I think, for a lot of people.
Yeah, and it's interesting how that changes from place in the country, because I'm in Texas, so for us we'll drive 2 hours for a party.
Right.
But it's not a hard traffic, so you do have to think. One of the things that's been mentioned in a lot of the interviews that I'm curious about from y'all's perspective is, how are you using telehealth, or are you using any more telehealth?
Yeah. So I will say that this crisis has really spiked in terms of, I guess we have a real spike in our use of telehealth as well as other technologies, right? Technology is here to stay for sure. We were using telehealth throughout our system, but in very small pocketed areas where some of our specialty services did conduct telehealth visits with patients. We're in overdrive now, and we started predominantly with the primary care offices. So the connection between the call center and the primary care offices, in week 1, we were making phone calls to schedule or scheduling patients online. By week 2, we were scheduling televisits for them, and patients are asking for them. So we did a telephone screening, and as we were scheduling our patients, we were looking in the schedule, and by week 2, we were able to start dropping in telehealth visits. And huge satisfier, especially in a time where virus is, something you can't see is what's impacting you. That reluctance to go into a doctor's office was a huge driver, and the efficiency to be able to stay home and be reassured and see a person as you're being either triaged or seen in the office setting, really huge benefit to our families. So we started with primary care, and from there we really expanded into our hospitals. And in the hospital made a shift that was obviously not primary care anymore. So we are now, we've deployed probably more than 1,000 devices, tablets throughout our hospitals, so that patients can see out to their loved ones, and you can have that bi-directional communication and reassurance from their own family members. It's become a huge benefit to our patients, our caregivers, our families. An interesting story, just last week, we were deploying a tablet, and because the tablets don't have a really high volume, we wanted to have speakers attached to it. Well, you can't have, in some tablets, you can't have both speakers or headphones and a power cord, and we needed to maintain power on these. And so our staff got really creative, and they remembered that, I guess in the last year or so, we had been given little Bluetooth speakers that were, you know, an employee gift. And they found a couple of those speakers, and they hardwired them to the tablet so that you could still maintain having it plugged in, and you could still have, you know, this better volume and communication with the larger speakers. It worked so well. They got our engineering folks involved, and they went to HR, and they found all the extra speakers that they could find, and they've like rigged these speakers and have deployed a much better patient experience by giving the patients the ability to better hear their families and hear their caregivers when they're not in the room with them. So it's really been it was really a great innovative example of how, you know, our teams can be creative. It was wonderful.
Yeah, that's also a common theme over the last few days has been innovation, you know, that really thinking about, okay, what's our problem? How do we solve it with what we've got? And given some of the changes in regulations, and I read a tweet the other day and said, last week we couldn't put a piece of tape on the wall, and now we're doing all these other kind of things. It's like, okay, you know, maybe we're, and I'm been fascinated to see some of the models go back to models that I used when I got out of nursing school 43 years ago.
Yeah.
That are turning around and coming back.
Right.
So that we can provide the kind of care we need, which I think is phenomenal.
Yeah, you know, one of the other things, in speaking of innovation, and, you know, obviously we've had challenges across the country with our PPE, right? And so not only to limit travel in and out of a patient room for infection prevention, but also that conservation of our PPE. We have one of our respiratory therapists got really innovative, and since we had glass doors on our patient rooms, they would start putting the vent settings, writing them right, you know, in the whiteboard marker right on the door, so that people could see from the outside without going in to see what those vent settings were. So just really, this is really bringing out the best in people in most cases, and we're all stressed, we're all tired, but it's the organization is pulling together as one team.
Yeah, that's certainly something I'm hearing, you know, and reading, because I'm trying to keep up with the different listservs and those kind of things. So yeah, it's been great. So what have you learned about informatics and the impact that informatics has had in this crisis, and what do you think you're going to see going forward?
Well, in terms of impact, one of the things I've learned is that, and nurses, we're good at it. We're good at pivoting. You know, the informatics nurses, there are only 6, but in this crisis, they've been telephone triage nurses. 2 of them are now deployed to our EICU. 2 of them are going to be working for a while in the central staffing office. And so they've learned new skills. You know, and as nurses, we do that, but taking our clinical knowledge and marrying it with the technology, we can be used in a number of different areas. We can't be out deploying new pumps right now or new technologies. And so what can we do that is really going to help in our frontline caregivers? So that was one of the learnings, that, you know, we're really good at pivoting, but cross-training your teams to different areas that makes sense, that's awesome. And I think that's one thing that we've learned. One of the things that is not going away is our use of technology. We will now embrace those those televisits. We will be, the video visits, we will be utilizing them, I think, to a much greater and thoughtful, there's a cat in the background.
The joys of being at home. Yes, she's outside her normal environment, and she's like, no, we should all be asleep at this time.
I know. But anyway, so many of the technologies that we have deployed, we will not be taking back again. So when the crisis started, we started getting our workers out of office buildings and sending them home to work remotely. So the technology and the work at home model is going to, I think, will be very lasting in many cases. So call center technology does not have to be always in a physical space. There are benefits for sure, but there are also a lot of benefits to being at home where you can be, one of the biggest things, I guess, is that you could be doing your day job as your informatics nurse and doing what you need to on the computers. But if we have a crisis, or if we have an emergency or a surge of call volume, you can pivot, you can log in, you can switch jobs in the moment and be able to support in a really timely manner. So I think those are the things. So, I mean, learning how to cross-train and pivot when you need to, and taking advantage of the technologies that we've put in place in this crisis and really optimizing them going forward.
I totally agree with you. I've worked from home for pushing 25 years now.
Wow.
And I mean, I did a lot of traveling in some of that, but when I was home, I did not go into an office. I worked from home. And it's like, yeah, I get much more work done here than I do if I go on campus, quite frankly, because then I'm visiting and
Right.
running around and going having lunch and having a good time. So I'm curious, one of the people I interviewed yesterday started talking about what she referred to as the second wave. And I thought I knew what she was talking about, another wave of COVID. But what she was actually talking about was post-COVID, when the wave of patients, that the stuff we put off,
right,
the elective surgeries, the primary care stuff, when all that hits, are you starting to give any thought to ways that you might handle that influx of patients?
Well, I think we're constantly planning. I think we're kind of pausing right now. We are really just starting to peak. And so really our focus at this point is on making sure that we have our teams in the right place to take care of our patients, so that no one hospital is overwhelmed while others are potentially, giving team members time back. So that's our focus at the moment. As we think about the future, we're excited to have that wave of patients come back, and we are going to have to really thoughtfully plan for that. I think our senior execs and our senior leadership has really given that a great deal of consideration. But right now, at the team level, it's very hard to think about just yet. We know that there are a lot of elective surgeries, and there's probably hips and shoulders and things that are waiting out there to be replaced. We will, we have every intention of making sure that we have the team members in place to support that when the time comes. But really right now, we're worrying about today, because right now we are really just starting to be in the thick of things.
Yeah, that makes perfect sense.
Yeah.
Anything else, Maggie, that you wanted to share today that we didn't talk about?
No, Cheryl, I think from the informatics standpoint, we're in a wonderful position to really utilize the technologies that we have. I guess the last thing that we really didn't touch on was the reporting aspect of this. So we have wonderful reporting talent that works with us to stand up our dashboard so that we can see what's happening within our system and across the country, and get that information not only to our execs but to our front line, so that they have a view into our whole health system. Just great things happening, and I can't think of a better time to be in informatics to be able to help support it any way we can.
Totally. I absolutely agree with you, Maggie.
Yeah.
Well, I thank you so much for coming in early and taking some time with us today. I really do appreciate it. And I wish you guys the best of luck in your surge. I think ours is probably here maybe a month behind you. So we're trying to learn, we learn from those who go ahead of us. And I think that's been the major purpose of these interviews, is to try and share the knowledge so we're not out recreating the wheel, but
Right.
we can take learnings from each other. So again,
That's right.
thanks, best of luck, stay safe and stay healthy, and we'll be talking to you soon.
Great. Thanks so much, Cheryl.
Thank you.